My name is Caroline MacCallum. I'm an internal medicine specialist, and I work with patients with complex disease, complex pain, and with cannabis medicine. Today I'm going to be talking about 2 patient cases and taking the audience through questions that are important to consider before using cannabis medicine, including if there's a good indication for cannabis, if there's reasons not to consider cannabis, drug interactions, how to dose cannabis, how to monitor for cannabis, and potentially taper other medications off as patients get benefit from cannabis if that is appropriate.
And without further ado, I'd like to introduce our first speaker. I can't tell you how incredibly excited I am that we have Dr. Caroline MacCallum here today. If anyone has had a chance to hear her speak, or if you have Twitter, get Twitter. Subscribe to her feeds. We have a person who's a physician, who's a pharmacist, who's a researcher, and you know what? Someone who has influenced our ability to work clinically by being one of the only researchers talking about how to actually apply cannabis in a clinical fashion to go beyond the promise or the hope of cannabis, but actually to more, this is how you need to think about this. These are the areas of interest and ways in which you can get involved in this. Now, Dr. MacCallum, she's an internal medicine specialist with expertise in complex pain and cannabinoid medicine. She's a clinical instructor in the Department of Medicine, an adjunct professor in the Faculty of Pharmaceutical Sciences program, and an associate member in the Department of Palliative Care at the University of British Columbia. She's the medical director at the Greenleaf Medical Clinic, where she's assessed and developed cannabinoid treatment plans for more than 3,000 patients. Using legal medical cannabis approved by Health Canada just in the past 5 years. In addition, she's the co-author of the publication Practical Consideration for Medical Cannabis Administration and Dosing, a seminal paper in this field that I use personally to fuel my knowledge, my understanding, and my clinical practice. It was a game changer for me, and she's going to talk a little bit about that today for you. She's presented internationally on the topic of cannabis dosing and cannabis and opioids. She's the expert for several medical cannabis courses, is qualified as a medical cannabis expert, testified in arbitration involving a challenge to Health Canada's 24-hour rule for cannabis impairment. She's working with university research groups, this goes on, hospitals, health benefit programs, provincial and national committees to create cannabis guidelines. Safe THC prescribing practices, clinical trials, patient registries, and adverse event monitoring. She's particularly interested in studying cannabis as a therapeutic option for complex conditions, as a substitute for opioid and polypharmacy reduction, for standardized product and testing and impairment. Whew. Without further ado, it is my sincere pleasure to welcome Dr. Caroline MacCallum to the stage.
Thank you so much. I'm so excited to be here today. This was such a nice little drive. I haven't made my way to Kamloops before, and had a nice evening last night meeting some of the people in this community that really have been doing some great work with cannabis. So in the next 30 minutes, I'd like to take us through a couple patient cases and show you how I apply some of the pearls in the paper that's actually included in your handout, which is a paper that I wrote with my mentor, Ethan Russo, and show you how I apply it to patients. So just going through before I get started, some disclosures. I've worked with a number of different cannabis companies and in different capacities, helping with putting together health benefit plans and choosing cannabis strains, what I find can be helpful for different types of conditions and so forth. So we're going to talk a little bit before we dive into the cases just about the endocannabinoid system and cannabinoids in general, just so you have a sense of a bit of the science behind it. We could spend a full hour on just this topic, so I'm going to just try to hit the highlights here. So I'm sure that most of us in the room know that cannabis is a plant, and you can see here in terms of, I've got the different species here, sativa and indica, and I don't want to go down down that rabbit hole right now because it is such a varied experience for patients. Some that will say that indicas may make them feel really sedated and that it could help them for sleep. Others can say, oh, indicas can be quite uplifting for me. So really, I don't like to generalize the plant in that regard, but to say that there are species and certainly hybrids that many patients use. We can see there's over 500 chemical compounds in the plant. So that's what makes this difficult to put a DIN number on that, because those 500 compounds are changing with every strain that's being grown. But the main point right here, and trying to focus in on the phytocannabinoids. So that's your CBD, your THC, and other cannabinoids like CBG and CBV that every day we're learning more and more about. And I think that at some point in time, we're going to start to see that different individual cannabinoids may be better suited for individual disease states, or we may find that combinations of those are best for a particular condition. So again, the entourage effect, which is being referenced at the bottom of this page, is this idea that it's the sum of the plant together that is working perhaps better than any one individual component. And also to mention that we talk about CBD and THC as the two main heavy lifters in this plant, and I really like to clarify here that cannabidiol is psychoactive, and that means it crosses the blood-brain barrier and has an effect on the brain, but that doesn't mean that it causes impairment. So some people confuse psychoactivity with impairment or euphoria, but because both THC and CBD work on the brain, for example, CBD is used for seizures, so we know it's working on the brain, but we think of it more as something that's a non-euphoric agent, whereas THC can cause euphoria depending on what doses are used. But basically, the major differences between the two molecules, I would say, is that CBD I'm looking at more for anti-inflammatory properties, for the neuroprotection, for the antipsychotic, and for the anti-seizure effects. Whereas THC, there is quite an overlap with some of the characteristics it has and what CBD have as well. But a major difference with THC, I find it very good for neuropathic pain. So for more difficult pain, as well as the potential that it could cause euphoria. But most times I'm trying to use CBD where I can and then layering on THC as I go along. So looking at the endocannabinoid system, we can see that it's diffusely spread throughout the body. The CB1 receptors are primarily localized in the central nervous system. So you're going to see that's in blue in the image here, and that the CB2 receptors are largely found in the immune system as well as the hematopoietic system. And so they are pretty much found in every organ in the body, and that's why, people kind of joke, like, can cannabis treat everything? And I think that over time we're going to start to see different molecules being looked at potentially for different conditions. And I'm not here to say that it is possible for it to treat every condition, but it's interesting that the system is diffusely spread in the body, and there may be potentials to change how the system is operating. An example that comes to mind is a recent case report that I read about a 70-year-old patient who had a surgery. She had a really painful wrist surgery, and in the post-operative recovery unit, the anesthesiologist was surprised that she wasn't requiring morphine. And so he was quite astute, and he decided to grab took some blood. I guess he quickly got consent, and then they studied it, and she actually had 10 times the normal amount of anandamide. So anandamide is one of our natural produced, you'll see on the next slide, anandamide is produced naturally in the body. And it's basically a natural painkiller. And I think what we're going to start to see is that some people have an overactive or an underactive or normally active endocannabinoid system. And sometimes we refer to this as an endocannabinoid tone. And so in this case, we could see that for her, she actually, on a deeper dive into her history, she had all these broken bones and burns and injuries out of clumsiness because she actually didn't have awareness of pain. So she was just naturally producing all this extra pain medication. And so getting back to this endocannabinoid system, and this is one potential mechanism for how it may be possible that cannabis is helping in pain. Particularly here, we're looking at here a GABA neuron, and looking at the presynaptic and postsynaptic neuron. I know that this is a lot of words and it's sounding complicated, but what I really just want to point out here, if I can project, is the CB1 receptor here, and you can see THC, and this says other cannabinoids, so this potentially is nabilone. This is the anandamide that we're producing, and 2-AG, which we're also producing naturally every day in our body, even if we don't have a pain problem or we don't have a disease going on. We're using these naturally, and when this receptor is activated, there's a lot of different pathways that are turned on, and then what ends up happening is calcium no longer comes in here, and therefore we can't secrete these neurotransmitters. So the goal potentially for some patients would be to cut down the neuron, the impulse in this particular pathway. And so this is just one mechanism, and this could also apply to other pathways like dopamine, acetylcholine, serotonin, and this is just pain, let alone anxiety and other conditions. So we can start to see how complicated this is, as well as I haven't even acknowledged CBD, which is actually having an effect down here on these other enzymes that are indirectly increasing our natural endocannabinoids. So I think that there's still loads to be figured out when it comes to the plant, but just to give you an idea of, I joke how promiscuous cannabis can be, in the sense that it can work on so many different pathways, and this is in comparison to other prescription medications that you'll see really just fall in one or two categories. And that has worked for pharma because they've been able to put a patent on that particular compound working in this particular way, whereas we see cannabis may be able to affect the sodium channels, the calcium channels, the NMDA channels. And then up above, I've already touched on this endocannabinoid tone and other areas like glial cell health. So really we're just at the tip of the iceberg when it comes to our knowledge of cannabis. And that's what makes this plant tricky, is that because we don't fully understand exactly how it works, therefore companies haven't invested as much money as we would like into doing this research so that we can really tease out exactly how much and exactly how it works. So that is one of the frustrations we're dealing with. However, I'm going to be sharing in the next couple slides some of the evidence that we do have and the evidence that I rely on in my practice. So moving along to talk about indications and contraindications for cannabis. So the first document is largely, it's written by a group of family physicians. It's a few years old. I think it could use a refresher. And since that time, we've moved on and seen some other documents evolve from here. But this document in the middle is from the Canadian Pain Society, and focusing a lot on neuropathic pain. And so looking at other agents like gabapentin and tramadol and amitriptyline and tricyclics and other agents, and really trying to see where cannabis can fit in amongst these other therapeutics. And I know Dr. Mitchell's going to be speaking about gabapentin a little bit, and so we'll start to hear about these other medications. And the challenge with some of them is that we don't actually have great studies in those either. But guess what? Every day we do use them. And the reason is because as a physician, you have to work with the tools you have. And we don't stop and say, well, I can't use this drug. Well, some people do say, I can't use this drug because I don't have a study. Instead, you may think, well, some patients have reported it worked, so let's see if it may work, if it's appropriate for that particular patient. And just moving along to the last document, this one here, it's by the National Academies of Science, Engineering, and Medicine, and it's probably my favorite document, 350 pages, so please only read the summary versions of 4 and 6 pages, which you can find on my website. It's done a really good job of highlighting the safety concerns, looking at some of the evidence. For example, can cannabis cause lung disease, or can it cause heart disease, and some of the other issues that we're dealing with on a daily basis in cannabis. So the best evidence for cannabis from the studies that have been reviewed are largely in the areas of neuropathic pain, nausea and vomiting relating to chemotherapy, and spasticity relating to multiple sclerosis. So I have extrapolated some of that information, and I know a number of other physicians have done the same, that nausea and vomiting, if it works for chemotherapy, may it work for other forms of nausea and vomiting? And likewise, spasticity, if it works for multiple sclerosis spasticity, could it work for other forms of spasticity? So this really is, you need to be a bit fluid in working with the information, because there isn't a study for every disease that we would like. And then moving on to moderate evidence, we can see there is some for sleep, and then limited, you can see other conditions listed here, such as Tourette syndrome, weight loss, and anorexia associated with HIV and other conditions. But I guess the bottom line of this slide that I like to remind the audience is that lack of evidence, so not having studies, does not mean lack of efficacy. So it doesn't mean the plant doesn't work. It just means we haven't shown it in a robust model that it doesn't work. That it does work. But really, I think that patients speak volumes, and there's been hundreds of thousands of patients that have been using this plant effectively, and that's kind of where we have to go with some of this, is we do have to color outside the lines when we don't have other better studies and other medications. So just touching on contraindications, so there's some listed here again from that document, and reminding you that this document is largely focusing on THC, and it doesn't really speak to CBD, because 5 years ago we didn't really talk about that, and it also is focusing on smoked cannabis, so not vaporized and not oils. I think overall that there's some broad strokes that may be, appropriate, that people under 25 years of age, we should be careful in using THC. I have used it in certain circumstances, but making sure that we've tried other means and that we have other specialists involved if appropriate, such as pediatricians and psychiatrists. Also touching on family history of psychosis. If we already know somebody potentially has at risk of schizophrenia, we do know that THC at times can put them at risk for having a break, or perhaps they would have developed schizophrenia already, but it could make it kind of reveal earlier than that might have happened. But people then take, this and they run with it, and they say, oh, cannabis causes psychosis. And this is a bigger discussion about association and causation, which I don't have the time to do today, but to say that with a lot of medications, on the market, I've had patients go psychotic on gabapentin and on tramadol, and it doesn't mean that cannabis should be treated any special or is different or is worse. We have these risks and benefits with every medicine that we use, and we really need to do a good job of weighing them before we give them to a particular patient. And we do this by asking good questions, and I'll get to those questions shortly. But basically, somebody who has active substance use, honestly, I really don't like this comment here, because heroin is going to kill you much faster than cannabis, if cannabis ever will kill you, based on toxicity studies. Not to say you couldn't get in a car accident using cannabis, or potentially feel psychotic on it, but I'm talking about looking at morbidity and mortality. We certainly see that there are other drugs out there that are more dangerous, and so I do think this could have some value for harm reduction. And then also for cardiac disease, if your heart condition is controlled and you're on good medications, and you don't have chest pain and worrisome symptoms, cannabis may be okay to use, and I certainly have used it and started with CBD before going to THC. And again, pregnancy makes sense. We would want to be careful because we don't know enough. And these other conditions that I've listed below, or that have been pulled from this document, are just risk factors that may be associated with some of the other more concerning conditions above, and just really want to be careful with these patients. So I guess the bottom line here is that some physicians will use cannabis in conditions where other treatment options have failed or just were not tolerated. And so, it needs to be on the table. It's an option, it's a tool, and it certainly does not have the evidence to say cannabis should be first line for any condition out there. So moving along to talk about the paper that, and the reason why I wrote this paper was because I didn't feel that there was a standardized approach. I wanted all patients to be able to have the same access to this information, and for their care providers to know what I know, and to be able to help them make informed decisions, because it isn't quite the same as taking one blood pressure pill once a day. There is definitely some nuances that need to be understood, and troubleshooting when they come back and follow up to understand why they're having that particular symptom. So I think it was all included in your package, a copy of my paper, but again, it's on my website if you'd like to have it and share it with others. But talking about a good clinical approach, so here are some questions that I asked my myself frequently before authorizing a patient for cannabis. So looking at what is the evidence for the condition they're coming into the office for, so Crohn's or whether it's seizure disorder, what does the evidence say? And have they tried other appropriate medications before seeing me? What are their goals? I've had patients come in and say, oh, my granddaughter told me that this is going to cure my cancer. And so these are really, delicate conversations that need to happen, because if their expectations aren't matching what's happening, then they may be increasing their doses without our supervision. And just there's a disconnect between the patient's needs and what I'm able to support them with. And then also looking at, do they have contraindications? Are there drug interactions? What are the risks and benefits potentially? If somebody has Parkinson's disease and they're 80 years old and their blood pressure is 80/40 and they're already falling over with low blood pressure, THC at times can lower blood pressure, not always. And certainly if we start low and go slow, I haven't had that be a particular issue, but we just need to be aware of these circumstances. And then finally, how do we increase the dose? How quickly do we increase it? And when do we consider tapering other medications? So if you forget everything else that I've talked about today, the next couple slides are really the take-home ones anyway. So the first question, is the symptom in the daytime or in the nighttime? Because if I can reserve THC for sleep, that's probably the best thing that we can do, is to not use it in the daytime if we don't need to. Now, I have many patients that do use it, and we're just careful on how we go about that. And I mentioned here in particular about myrcene. So myrcene is a terpene in the plant that can cause a feeling of sedation or relaxation. So some people like plants that are more dominant in myrcene for sleep, for example. And for the daytime, they may want to avoid myrcene. It just depends on the person. Again, what type of symptom do they have? Is this an acute symptom that comes on out of the blue? And if so, vaporization makes sense because it's going to work very quickly. And then if it's a chronic symptom, they're going to want an oil that lasts for a longer period of time and gives them greater control over their symptoms. In terms of the pathophysiology, I'm also thinking, is this an inflammatory condition? So in that case, CBD may be better than THC. And then if it's neurological, like a diabetic neuropathic pain, sometimes I do find that THC certainly can be more helpful. And then two last considerations are special populations. I've already alluded to children and people with low blood pressures and elderly and frail. Those patients maybe start with a lower dose of THC. That can be a better, safer place to go, and then or avoiding it altogether. And then lastly, I always add cannabis to the medical regimen, to the prescriptions or the other medicines, and then I start to do a taper afterwards, because I find they're better able to tolerate the taper when they already have cannabis working in the background. So moving along to the first of the two cases, this one I really wanted to highlight dosing and different delivery routes. And really, this is a very typical patient, and you really could substitute any form of pain, neuropathic pain here. I chose fibromyalgia because it's something that I see quite a lot of. But basically, this is a 45-year-old who has children, so it's really important for us to listen to what her goals are. And so one of her most important things that she said before she even sat down was, I have kids and I have to be able to drive my car. So, or, I'm really worried about being impaired. And so certainly I make note of spending extra time talking about these issues that are important for her, because I can help her pain, but if I make her impaired, she's not going to be happy about that. And you can see from her medication regimen that she's tried a number of different medications, and they just haven't been helpful or cause side effects. And especially the opioids, a lot of patients come and say, I feel itchy, I feel sweaty, I feel nauseous, I feel confused, and I just want to get off them. I'd rather be in pain than have these side effects. So certainly that's sometimes when I see patients, is when they've really tried it all. And so for her, we talked a little bit about what would be the smartest route of administration. So it makes sense that if she wants to drive the car at 8 a.m. and 3 p.m. when she's driving her kids to school, she may want to consider using something like CBD in the daytime, and then maybe using vaporization intermittently in the daytime when she may need some extra pain relief, but she wants to be able to drive later on. And so looking here in terms of the different options we have, you can start to see the first column, your inhalation route, is going to be your rapid acting. So think about insulin that some people take at meals. It works quickly, but it doesn't last that long. Versus the second column, which is your oral oils, they don't work as quickly, but they last longer. So that's your background insulin, like your NPH or your Lantus, your long-acting insulin. I like to use insulin as an analogy because I think it does it justice in showing that sometimes people need long-acting only, short-acting, not usually only, but unless they've got a pump, and then a combination of both is frequently something that I see. The third column, oral mucosa, is Sativex, which is a prescription. It could refer to also tinctures. However, currently tinctures are not legal. There are people who still use them, but basically it's cannabis in a solution, like an alcohol-based solution that absorbs quickly from the mouth. And that's why you'll see the time of onset is quicker than the oils, but a little slower than the vaporization, and it lasts about the same amount of time as the oils because it is being swallowed, and the liver is activating it to the 11-hydroxy-THC, which gives it that longer duration of action like an oil, and the inhalation route doesn't give you that intermediate, so that's why you don't get that long-acting ability. And then lastly, topicals. My elderly patients love them. There are very few studies on them at all. They work between 15 and 30 minutes overall, and it's really nice if you've got a sore hand, you've got arthritis in your knee, especially a bony area, I find, where the penetration is really good. And we actually know that there's a lot of CB2 receptors lining the synovium membranes. So those are the membranes around the joints. So I find that to be a really great option. Or for people with skin condition, I see psoriasis, eczema, acne. I'm sure we'll start to see cosmetics and other things down the road, but it is an option, but not an option for somebody who has fibromyalgia and pain all over their body. Not a good idea to be putting cream everywhere because we just don't know what the absorption would be in that matter, and you're just better off to use an oil. So moving on to talk a little bit about dosing, and again, it's in the paper for your reference, so you don't have to remember these numbers or take pictures. It's all provided. But basically, CBD, I'm just looking at my time, I have 5 minutes, and I haven't even made it through this case, so I'm just going to quickly move along. But CBD 5 to 10 milligrams a couple times a day is a great starting place, and to go up from there, really trying at least 50 a day before we say this isn't working, and then moving along to potentially adding THC on. I always start at bedtime because if there's a side effect, it's a good way to sleep through the side effect. And then considering introducing it in the daytime only if need be. And for vaporization, I was having a discussion with Dr. Mitchell before I came up here, and I was saying the interesting thing about vaporization is I wonder if sometimes it's really working because patients actually start breathing. If you think about vaporization, you're taking a deep breath. Usually patients are holding their breath and then exhaling. It's almost this form of box breathing, which is a mindful practice and which gets you back in your body and checking in. And so I think it's really important to vaporize effectively, and that means turning off the vaporizer between so many inhalations and seeing if it's working and not assuming you need to fill the vaporizer full. So I'm just going to flick through some of the questions because I've pretty much answered them anyways as I've gone along. For vaporization, just one point is I usually recommend THC as a rescue and medicine to be inhaled. Usually CBD is in an oil format that patients are using. For the topical, I'm using a combination of CBD and THC, but you know what? CBD alone can be effective, and then patients get creative and they make their own combinations. If she was wanting to taper off her opioids, in my experience, I find that CBD isn't enough, that they do need some THC in the background. However, I think that also can vary because if it's largely anxiety that's exacerbating the pain, perhaps the CBD is enough to manage the anxiety that they don't actually need that much THC. So I say usually, but it doesn't mean always. And then just a couple points on addiction before I wrap up and take some questions. This particular case was a patient who came to me who very much had a recreational undertone before I even met him. He then happened to go on and develop multiple sclerosis, but was using 10 grams a day and using it only between 6 p.m. and 10 p.m. at night, and only smoking it and only THC. And as soon as I start to hear this only works and if it's done this way, I start to get a sense of, well, I'm not really sure this is the best way for this person to utilize it. And so what we talked a lot about was talking about vaporization instead of smoking, and moving on to how we can reduce harm of the long-term consequences of smoking any substance. And just for the audience, smoking is different. You do make tars, ammonia, polyaromatic hydrocarbons, and you're depositing that soot in the lungs. And with vaporization, we don't have 20 years worth of long-term data, but we certainly see that there is a lot lower quantities of those particular particles, and that's really important. And then patients mix tobacco with their cannabis, and then they smoke both, which is worse. So again, we spend a lot of our time on vaporizing, and I really encourage patients to buy a vaporizer that they love and that is easy to use and it fits in their pocket, because if they buy, the Volcano, which are these big clunky vaporizers, or ones that have a lot of buttons that aren't easy to use, what happens is when they leave the house, they actually roll a joint because it's easier. So it's really making sure they've got a device that they find user-friendly, and that works well for them. So not to belabor that, but in this particular case, I did want to highlight, because people will say, well, is cannabis addictive, and is he addicted? Yes, he's got some features of problematic cannabis use in my mind. I don't necessarily want to diagnose him with cannabis use disorder quite yet, but to draw on some evidence that is very outdated from the 1980s or 1990s, is basically pulling on recreational patients and just looking at cannabis versus tobacco, so THC versus tobacco, heroin, cocaine, and starting to see that the percent dependency is around 9, and just to put this in context, caffeine is around 7%. So certainly, yes, there may be some potential in some people using this recreationally, but in my medical practice, I really haven't seen much in the way of addiction. And I think that's because we spend so much time educating, and they're using just a lot less medicine, which is great because they save money, and they actually have less side effects, which is our goal, is to get them relief without having side effects. And just to bring it up, I just still think it's really important that we screen for addiction, even though this isn't something that I've seen a lot in my medical practice. I tend to use the ORT, the opioid risk tool, because I'm familiar with it, but there's a new one called the QDIT, which is focused on cannabis, and specific to that, but a lot of them have very similar questions. And I think one point about the QDIT that not a lot of people are aware of is that one of the questions in that asks, do you use cannabis daily? And so if you use cannabis daily, you get 4 points. So that could be enough to push somebody over the edge and call them, oh, they're at risk of addiction now. Their score is high, when really they're using it daily because they're using it as a medicine. So you may want to consider subtracting 4 points off some of the scores, depending on if you're using it and what the circumstances are, because that shouldn't be the deal breaker. And actually, I've used cannabis with people that have high risk, like 15 out of 15 or whatever the max score is for the ORT. Because really, if I don't, walk with them and help them use this medicine, they're going to go use THC, they're going to smoke it, and they're probably using worse substances. Especially in Vancouver, we're seeing crystal meth and a lot of other drugs that I think have way worse outcomes. So really, it's how do we engage patients and how do we keep them under our care, because that's really going to be where we can change the game, I guess. So for this patient, what I really just wanted to highlight was, for him, I wanted him to use CBD. I know he's going to use some THC. He's going to want 10 grams. I'm only going to give him 2 because that's all I feel medically I can support him and reasonably what makes sense for him to use. I really want him to use oils because they're going to last longer. He has MS. He wants to prevent the MS from coming back. So we want this medicine to work 24 hours a day. We don't want him to only smoke it from 6 p.m. to 10 p.m. Like, that doesn't really make sense as a medicine. For him, topicals wouldn't make sense. And then looking at his score, again, it really wouldn't change anything for me other than giving him less, bringing him back more frequently, and making sure he's not doing more harm. And if he comes back and tells me the THC he's using is causing him a lot of side effects, having a bit more of a conversation on that. And then lastly, to talk about a treatment plan, which is something that I don't think happens in all cannabis clinics, but is very important. So basically, it's an agreement that I have with a patient, and I say it's really important that you and I know that we're signing up for the same thing here. You're only going to come to me. You're not going to drive if you're impaired. You're not going to only buy THC when we've had a discussion that there should be some CBD there. If you're pregnant, you're going to be careful, and just a lot of motherhood statements. But I think when we go, if there's a a disconnect at some point, we can go back and say, hey, this wasn't what we talked about. And also it allows me the opportunity to call up their licensed producer and ask, can you send me a printout of what he actually purchased? Because I had him sign to say that was okay for me to ask. So it's a little bit of a due diligence that I think is very helpful. But certainly I have a lot more resources available on my website that are free for download, and please share them. And I'm quite active on Twitter trying to spread the message about the difficult conversations, drug interactions, cardiac symptoms, and the vape crisis, or whatever the new trendy topic is of concern in the media. But I'd love to take some questions from the audience if there's any burning questions out there. Pardon? 11 minutes for questions. Okay, great.
So if people have questions, I'll bring the microphone over.
Thank you so much for that.
Oh, great.
My name is Selena from Flower of Life, and my question is, what do you recommend to patients that are wanting to access certain types of products that aren't legally available through the licensed producer program? So specifically high concentrated oils. I know topical lotions are coming online, but they're not quite available yet. Mm-hmm. And those types of products. What do you say to those patients, and how do you help guide their process?
That's a great question. Thank you so much. So just to make sure I got it right, so it's specifically the couple of products that you were wondering about were the high concentrates and the topicals. And edibles. Okay. So obviously in the next, now we're seeing the evolution of legalization. So that means these retail outlets that are government regulated, and they're using products that come from licensed producers that are apparently checked, and they're the cleanest and meeting the safety standards for Canadians. So in this rollout phase, we're starting to see extra products are going to be added onto this list. So some of the edibles, including whether it's going to be gummy bears or brownies or teas or various means, will be added on to this list. And topicals will be amongst those as well. Those aren't edibles, but they'll be added. My concern about the high concentrates is, I just want to get this right because I don't want this to be misunderstood. My first question is, why do you need a high concentrate? Where I go is, in my experience working with patients, I don't feel that doses of THC greater than, in the paper I use, for example, 30 to 50 milligrams of THC, once exceeding that, the medical benefit may not outweigh the risks of having that. However, there are some conditions, some cancers that we've seen, high potency THC, hundreds of milligrams, is what causes the anti-tumor effect, and that's where we potentially have seen benefit, not with all cancers, in some of these cases where we've seen these remissions. However, what I think is happening is patients are building a tolerance. So they need more and more concentrated medications, because the lower concentrations are no longer working because of tolerance. So at that point, I like to have a conversation about a washout, and to suggest that possibly it may mean that we just need to reset their receptors. So for example, when I have a patient that goes on vacation to the US and they're scared to buy cannabis or do anything with cannabis down there, and they go, usually 5 days is a decent washout, but up to 1 to 2 weeks for a full washout, probably 2 weeks. When they come back, they say, oh wow, I can't take that full dose that I was on. I can only now take 1 milligram or 2 milligrams instead of 10 or 15 of the THC. So it's really forced a reset, which can be really nice in some cases. The other thing is sometimes using more CBD, because the high concentrates are usually THC is what we're talking about. We're not talking about high concentrates CBD. I mean, maybe sometime, but it's usually THC. And so a lot of times I suggest, well, have you tried adding in some CBD? Because there may be a synergistic effect that you haven't appreciated yet. And also a lot of patients that require higher prescriptions or authorizations, if they're smoking it in particular, you actually smoke like 30 to 50% more when you're smoking and not vaping. So for me, the more they buy, the more money this is going to cost. Like, it's not just for their medical health that I'm concerned, it's for affordability. So I really like to understand why they need more. And then for some patients, perhaps it is the case that they need more. but a lot of times with higher concentrates can also come concentrated pesticides, concentrated heavy metals, and other things that come in those plants that make these concentrates, and butane and solvents and all this mess that we're starting to see in some of these vape pens that have been, illicitly or coming from the black market, or I hate calling it the black market, the unregulated market. And I think that we need to find a happy medium, because if we just say, no, this isn't allowed, it's still going to get those patients to go and get it elsewhere, when really I think basically it's education is where I'm going with this, is that they need a lot more education to understand why their needs are such, because certainly the evidence hasn't really supported why they would need those doses, in my experience. But a lot of these patients will say, I've been doing this for 20 years, I know what I need, you've been doing this for 5 years, you don't know. And in those circumstances, I've had a couple that have walked with me, and we've done it, I don't want to say my way, but we've tried what I've suggested, and they're like, whoa, I've had 80% improvement in my symptoms since doing it like this. So I think they've been doing the best they can. They've been self-medicating, but they've been self-medicating pre-CBD, pre-oils, having access to these other better products that may be better suited. So sorry, that was a really long-winded answer, because I wanted to touch on so many pieces there, but that gets me really jazzed, because I think that, there can be great health concerns potentially with using, those high doses. Yeah, thank you.
Question.
In the case of patient number 2, when you're dropping him from 10 grams of THC a day to 2 with a lot of CBD in it, do you get worried about withdrawal symptoms at all?
So great question. So about withdrawal symptoms in decreasing his dose, I will say he was definitely buying the other 8 grams from somewhere else. I didn't drop him from 10 to 2. I said, if I'm authorizing for medical purposes and we're talking about MS, we need to be talking about CBD, because this is an inflammatory condition. THC can help with the spasms, the nausea, the pain, but he was actually symptom-free when he came. He wanted to prevent the MS from coming back. So then we started talking about what can be helpful for MS, and that's where we went to CBD. So he was using largely THC, and I didn't feel like clinically he needed THC in that moment for what he was not experiencing. So he was using recreationally as the bottom line. And we kind of got to that point where he could see my point, but he never did come back and follow up to say that. And sometimes that happens, but the goal is he knows we're still there if he wants to. And I signed him in for some. But with regards to withdrawal, that's a great question. So withdrawal, the concern is, the issue may be more with THC. Certainly with CBD, what I've observed from patients is when they go away and they stop using it, the pain comes back, or the symptom comes back that they were using it. Even with THC, when patients go on vacation, they'll just say the same thing. Oh, my anxiety's back, or oh, my issues with sleep, are what they were before the medicine. I haven't seen true withdrawal from THC. Now, I'd love to hear, Dr. Mitchell's going to have his own perspective, but I don't work in the emergency room. I don't see a lot of rec use. I see medical. And so when I'm working with 2 grams a day of THC, people just stop it and go on vacation, and there's no issues at all. So I think it's probably going to be in those that are using more than 5 grams a day, maybe even higher, using THC dominant products that could. And from my knowledge, it has been reported, it is a thing, and the withdrawal would look like kind of similar things that we would see from an antidepressant withdrawal. So it can be irritability, it can be headaches, it can be nausea, it can be agitation, insomnia. It depends. I guess it could be more severe if you were using more, but they're usually not like opioid withdrawal. This is not the same comparison in the least. So I hope that helps.
Sorry. Something I was thinking about was when we start putting CBD in everything. Yeah. So say they start adding it to drinks, and there's a lot of Instagram stuff promoting this as a health thing, right? Mm-hmm. If you've got the endocannabinoid system is homeostatic, and people are on a healthy balance within that system, will the ECS system keep up with something if they're drinking it in their drinks, their coffee, and all the other stuff? Or could it possibly put that system out of balance if they're consuming that much, if they're healthy to begin with?
Right.
Because I don't hear much about that, but it's certainly on my mind now.
Yeah. This kind of reminds me of biohacking. You know, I mean, it's all about like what isn't on social media, or, you know, the celebrities, or, you know, how to be smarter, work faster, all these things. So I think it comes down to dose as well. So with regards to CBD, you know, could it prevent, you know, conditions? Like, could this be like a supplement that you take every day to optimize your the enzyme reactions going on in your body? How much is enough to replace what you're deficient in, but how do we even know you're deficient? I mean, but we take multivitamins. Many people take multivitamins every day, but we don't know that they're low in, you know, iron or whatever that is, and we kind of, one a day is okay. So I think it's kind of in that same kind of breath is saying, is this something that a little bit could be helpful versus, you know, doing big doses? I agree. Like, could it actually be you know, changing their system? But certainly the research that I'm very fascinated with is that for potentially preventing heart disease. So looking at atherosclerosis as an inflammatory process. So could CBD, you know, potentially reduce that inflammation for cancers and free radicals and that kind of physiology? Could CBD prevent some of that from happening? I mean, we don't have the data to support that yet, but we're starting to see animal studies, preclinical studies. Dementia is another one. That could it be preventative? I think that I always recommend patients journal or use an app. Strain Print is an app that patients commonly use in my clinic, and why I like that one in particular is I can access their data on my end, so I can start to see how they're doing. So I think it's looking at, am I getting adverse events from this? Like, if I'm taking, I don't know, 1,000 milligrams of CBD every day, and I'm actually really tired, and I'm actually nauseated, and I'm not functioning, then that would be an indicator that that's too much. But I think it's kind of finding, is it one coffee a day that you know, I had today, or tomorrow I may have two? It's kind of like finding out what works for you. But this is, you're talking about this area of wellness and preventative medicine, which is certainly like the hot topic. And yeah, let me know if you find any great information on this. I mean, another person that comes to mind, Dr. Dustin Sulak, who's a good friend of mine. He's in the U.S. and he's a very big proponent of like ultra low dose cannabis, so really low dose, and he uses a lot of THCA, CBDA, so the acidic forms, and again in combination with the whole plant in doing this in terms of a wellness support. Yeah.
Thank you very much. A big round of applause, please, for Dr. Carolyn MacCallum.